You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.
So welcome back to the podcast with myself, Owen Walker. In this session, we're going to be examining exertional heat injury within individuals undertaking endurance races, military exercises, or extreme activity. So we're going to draw a contrast and parallels to a number of different pathologies, including acute behavioural disturbance and others, and also what's happening both at the physiological level and some of the autonomic positive feedback mechanisms within exertional heat injury. So to do this, I have Harvey Pynn with me. Harvey is a lieutenant colonel within the British military and an emergency medicine and air ambulance consultant. Welcome to the podcast, Harvey.
Thanks, Owen. Great to be here. Thank you very much indeed for inviting me.
It's fantastic to have you on. So Harvey, I just wondered if we could just initially speak to the definition of exertional heat injury and just the wide-ranging spectrum that it can represent.
Yes, so thank you. So in terms of a broad definition, it is what it says on the tin, really. So in order to have exertional heat injury, you need to be exerting. So putting your body under physiological stress, and your body needs to get hot. So we talk about a core temperature of above 40.5 degrees. And I suppose at this point it's worth noting that exertional heat injury is a different pathophysiological process to classical heat injury. So exertional heat injury gets an awful lot of press, but actually is quite rare. Whereas classical heat injury is much, much more common and gets very, very little attention. And what I mean by classical heat injury is generally the very young or the very old getting cooked during heat waves in summer. So the summer that we've just had, I am certain that there would have been a huge spike in mortality in the older community from classical heat injury. So generally the elderly stuck in rooms that are getting very, very hot, and due to their comorbidities and the medications they may be taking, they lose the ability, they have impaired ability to lose heat, and so, for want of a better word, cook. But we're not here to talk about that, but it is worth just outlining that at this stage is what we're here to talk about is exertional heat injury, which is slightly different from classical heat injury.
So to that point, Harvey, it's probably relevant and prudent to ask sort of how your perspective has changed in understanding, and indeed maybe from a systematic or indeed institutional perspective, how we have changed our perception of heat and illness sort of over the past 10 years.
So I guess it's a good point. We've become more aware of exertional heat injury. I don't think the numbers of cases have probably increased any, but we've become more aware, as certainly as a military, in terms of an organizational awareness of exertional heat injury. There's been some high profile cases, as everyone will be aware, but we as an organization have become more aware, and me as an individual, I've become more aware through the experiential management of the process. So I don't think it's become much more common, but I do think we've become much more aware, and that is a good thing, because this is something that does cause morbidity and mortality in young service people, but also young athletes as well.
So just drilling down into maybe some of the details, if that's okay, around sort of the physiological mechanisms and indeed the positive feedback cycles that are occurring. Could you maybe speak to these and how they might look in reality?
So I suppose the thing to mention right at the start is, I suppose in medicine, we're very good at making a diagnosis and talking about a diagnosis. But when you're confronted with a patient, the patient is undifferentiated in front of you. And so I'll come back to answering your question in a minute directly, but in terms of in terms of pooling this group of patients together, I try to put them into the bracket of exertion associated collapse, because there's all sorts of things that can cause you to collapse in the heat. And one of those is hypoglycemia, hyponatremia, could be cardiac arrest, it could be a cardiac dysrhythmia. There are other rarer causes, so exertional collapse associated with sickle cell trait, really, really small print stuff. But when someone collapses in front of you, you've got an undifferentiated patient, and you need to work out what that patient has collapsed from to then try and determine what your treatment strategy is going to be. Obviously, in a military population, when people are exerting themselves, generally they're fit and well guys and girls, and so the most likely cause is heat. Generally, when the sort of warning signs of an exertional heat injury is someone who is struggling, falling off the back of the pack, falling off the pace, starting to get a little bit less coordinated, starting to become maybe a little bit less confused, less responsive to someone who is running alongside or walking alongside if you're carrying load, starting to sway, maybe looking up to the sky. They describe something called air hunger, when people are looking up to the sky and trying to take in great big lungfuls of air to try and compensate for their failing cardiovascular system. And eventually they will sway and stagger so much that they then collapse. I suppose for heat injury, the exertional heat stroke, the two features that we want people to look out for are sort of neurological dysfunction and an associated rise in core body temperature. The neurological dysfunction you can spot from the outside, but in order to get the full diagnosis, you need to take a core temperature. So that's one of the sort of first aid interventions in the collapsed athlete, is to get that core temperature. And we're looking for a core temperature above 40.5 degrees. But the neurological dysfunction is something that we should all be looking out for, that will point to a exertional heat stroke. And if you want to have a really good look at someone who I think has got an exertional heat stroke is if you YouTube Johnny Brownlee in Cozumel in Mexico at the end of his triathlon. That is someone is behaving like they've got exertional heat stroke, all over the road, looking up into the sky, a little bit confused, and that's probably the first signs of his brain cooking and his cerebellum being most affected. So staggering all over the place.
So Harvey, what I wanted to do really is just approach the sort of normalization of heat, just around around becoming acclimatized to the environment. But before I sort of do that, there's been a few real seminal cases within the military, both within sort of 2014, 15, 16, namely in South Wales around sort of selection periods, which almost don't have anything to do with acclimatization, but again, very much to your point, are around exertional heat injury, in what we would classify a non acclimatized climate. It's normalized to UK weather, albeit maybe a hot day within the UK. Could you maybe speak to some of the reflections on some of the seminal cases, and indeed how things change when an individual has to become acclimatized, because there is a difference between the exertion on one's physiology when you're abroad in a extremely humid climate versus in the UK weather?
Yeah, no, it's a good point. I mean, the seminal cases in South Wales were, I suppose, we probably don't need to call it unseasonably hot weather. It was a hot summer, and it's no secret the guys were on loaded marches, so they were carrying a fair amount of kit, and they were wearing quite a lot of clothing. So in conjunction with the hot weather, they were at risk, clearly. I suppose the important thing with heat injury is that we all still share 97, 98% of our genome with our African ancestors, and so we are we are inherently able to acclimatize to hot conditions. But living in the temperate climates that we do, we are all unacclimatized. The way we cope with exercising in hot conditions is that our body gets better at sweating, and it starts sweating at a lower body temperature. Because basically the pathophysiological process is all about our body is generating more heat than we can lose. And so we've got good ability to lose heat, i.e. through sweating, because that's really the only way we can lose this large amount of heat that our muscles are producing. The only way we can do that is via sweating. So in order to be acclimatized, we need to upregulate our sweating mechanisms. There's some other things that go on at the same time. So we increase our cardiovascular capability and generate an increased cardiac output. And our kidneys get better at retaining salts. But the main process is that we get better at sweating, and we start sweating earlier. That's what happens in the acclimatized individual. In the unacclimatized individual, our sweating mechanisms probably still work. As an athlete, our sweating mechanisms work, but they don't work as efficiently as they might do. And so in the UK environment, we consider all individuals to be unacclimatized. And we do have some hot days in the UK, and so if we are exerting ourselves as unacclimatized individuals in a UK on a UK day that is warm, then we are potentially putting ourselves at risk. The other thing that we don't really factor in the UK is it is actually quite a humid environment. It's a cool environment, it's a temperate environment, but it's quite humid. And humidity is the main component of the environment that was the most risky element of the environment when it comes to exertional heat injury. Because if the environment is humid, i.e. the air is saturated with water, it makes it more difficult for us to lose sweat. So you can lose loads and loads and loads of sweat in a hot, very hot, dry environment because the air has got no moisture in it. And so the body can lose lots of heat. But if you go to a temperate, humid environment, it actually is very difficult to lose heat. And so that's why sometimes we notice that when people come out of their winter hibernation in the UK and start doing their 10Ks in May, when actually the weather is not very particularly warm, but we do see quite a lot of heat injury in 10K fun runs. People get into trouble because it's a warmish day, but in a very unacclimatized individual who's probably taking some antihistamines because they've got a bit of hay fever, suddenly they're putting themselves at quite significant risk. And I don't want to overplay it, but you can see how these things happen. And so there is clearly a risk in the UK. And I think as a military, we probably get caught out more in the UK. When we go to a hot environment, we expect people to have a heat injury, and so we acclimatize rigorously. But actually, we forget that the UK can be quite hot and humid, and our individuals are all unacclimatized.
Just speaking sort of quite honestly, taking large groups away myself, both in the UK and abroad, in Central America, I've fallen prey to, I think, a lot of lackadaisical thinking based on my own capability at negating the group and the group's ability, and indeed the group's acclimatization or lack of. Could you maybe speak to sort of individual and environmental factors which play into exertional heat injury, which people could maybe think about from a risk mitigation perspective when sort of maybe taking groups away?
Yeah, so the group thing's really interesting, and there's some really fairly simple but effective group algorithms to use when it comes to acclimatization. So acclimatizing a group. So acclimatization takes a couple of weeks to have a full effect. Clearly, most people when they go away on trips, save the military environment where people go away for longer. But when people go away recreationally, they didn't go away for a long period of time. They might go away for 3 weeks, and it's going to take 2 weeks to acclimatize. So you don't want people to be sitting around doing nothing for those 2 weeks. And actually, acclimatization only is only effective when you work, i.e. when you exert yourself to a certain degree. So there's some really good algorithms out there that look at maximal heart rate. You take 75% of your maximal heart rate, and then you exercise the whole group to the lowest of the maximal heart rates, or 75% of the maximal heart rates, and you exercise people for 30 minutes, gentle exercise, go for a walk or go for a little jog, and then you measure people's heart rates, and if anyone's exceeded their 75%, then you cut the working period by a third the next time you do it, and that means that you're acclimatizing to the lowest common denominator. It's generally the oldest person in the group you're acclimatizing. And that's quite effective. It gets the group working together, and it gets everyone acclimatized. But the danger of acclimatizing individually is that people go off and do their own thing, and some people will push themselves harder than they should be. In terms of individual factors, there's loads and loads of individual factors that make people potentially more liable to a heat-related injury. Within this podcast, we're talking about the extreme end of heat injury, the exertional heat stroke, but there's loads of other sort of minor heat injuries. So heat exhaustion, sunburn really is a heat injury. Heat rash, all of the heat syncope, all of these things, they're all heat injuries. But the risk factors that make you more prone to getting the exertional heat stroke are things like high BMI. Body fat is a great insulator. It probably makes you much more functional in the cold weather environments, but in the hot weather environments, it makes your ability to lose heat that much harder. People with intercurrent illness, so if you go away and you've got a little diarrheal illness or a little cough, your body's trying to fight off those infections and makes you more prone to a heat related injury. Sunburn, if you've got sunburn, makes you rely on your skin to sweat, and if you burn your skin, you're burning your sweat glands, then they're less effective. So sunburn is a problem, and actually, after a period of sunburn, so up to 3 weeks after your episode of sunburn, you're more at risk of a heat related injury. So that's that. Prevention is much better than cure in that regard. What medications people are taking, age, cardiovascular fitness, lots and lots and lots of individual risk factors, and you can't eliminate them all. Bottom line is, you can't eliminate all of those risk factors, but what you can do is educate people. And some people take a little bit longer to acclimatize. I'm fair skinned, ginger hair, I take longer to acclimatize. I just know that. And so you have to work to the individual, and support the individual with their acclimatization.
So Harvey, you spoke about before around sort of cognitive signs and sort of neurological deficit being a real kind of indicator of severity or of heat stroke and or severe exertional heat injury. I suppose they're sort of the not so subtle signs, really. And I in the past have very much aggressively had to treat patients which have become acutely confused because of the heat, and indeed sometimes because of the cold. And at both ends of the spectrum, I think sort of neurological deficit is a real red flag that you've got to aggressively treat. But could you maybe speak to some of the not so subtle signs? And again, only having taken big groups, those that have started to slow down and filter towards the back end of the group, which I've sort of picked up, and you've got to encourage to drink or encourage to take fluids on board, trying to catch them early, so you're not having to aggressively treat them. Could you maybe speak to some of those?
Yeah, so it's really good points, and you want to pick these things up early before you get to the point where you need to aggressively treat a life-threatening illness. So it's about education. You can't be in all places at all times with your group, and if you are a group leader or you are the sort of medic responsible for a group, you need to impart the knowledge on other people as well. So we talk about buddy care and aid, but actually working as buddies within a group, if buddies should look out for these sort of subtle signs in each other. that they'll know their mates better than you will, and they'll know when their mates are struggling a bit, got some cramp, cramp suggests that you're getting a bit salt depleted, means you're getting a bit dehydrated, or it might be the case that, your buddy's getting up 3 times in the night to pee, and that's probably because they're drinking loads and loads of water and becoming hyponatremic. So all of these things can be factored into the education process before a trip, looking out for some of the signs. And what you want to do is empower people to spot the sort of minor, subtle deficiencies in others, and raise them to your awareness, and then you can scrutinize a little bit more. But it's all about spotting those little subtle signs. So people are falling to the back of the pack. They're not running at the same pace. So if you usually run together and one of you is really struggling, and your heart rate monitor is going off the scale, you as the medic aren't going to know that, but your buddy will know that, because it'll be clear that the girl or guy next to you is struggling a bit, and you can look over their heart rate monitor and you can see it's flashing. So it's empowering others to sort of do your work for you, but look out for others in the group who may be struggling. The difficulty is in the military context is that people, there's still that sort of stiff upper lip, and still people don't want to be seen as, the weakest or whatever, and people don't own up to struggling, and that's more difficult. You want people to say, look, I'm really struggling today. I don't know why, but I'm not myself today, and I'm really struggling, because there is a point where you can encourage people, and encouragement is good, but there comes a point where, in highly motivated people, you can encourage them to run or walk to the point of collapse, and clearly that is a bad thing. So in terms of our commanders and leaders, whether that is in the expedition setting or the military setting, we also need to educate them that encouragement is good, but there becomes a point whereby you've got to act. The alarm bell should be going off to think, actually, this person is beyond the point of encouragement. We need to stop them, and give them some rest. So it is important to empower everyone to look out for the signs of a heat-related injury or an impending collapse of any sort, before it happens, because otherwise you're then dealing with a life-threatening situation, whereas before you might have been dealing with something that actually you can treat really easily.
So just looking at maybe modalities of treatment, Harvey, and I sort of rolling 2 questions into one, really, around sort of more minor heat illness and then more major heat illness. And I suppose to answer the minor heat illness question around, I suppose myself, around just giving people oral rehydration salts, giving them rest, de-escalating the exercise, or just having breaks, taking layers off, and just doing the sensible things. So maybe just shifting towards more the aggressive, more acute treatments in your mind. What things would you be looking to institute?
So yeah, you're absolutely right. All those simple things, are effective, and that's those simple interventions really important. At the more severe end, you've got your collapsed patient in front of you. As I said, this patient is undifferentiated, so you need to approach them with the open mindset. The sort of CABCDE approach. And then you want to rule things out and rule things in. So, checking for pulses, make sure it's not a cardiac arrest. Checking for responsive level, check a blood sugar, get a temperature measurement. Gold standard sort of temperature measurement is a rectal probe, but the rectal probe needs to be 15 centimeters in up the rectum, and so not all parties are going to carry the ability to do that. So if you haven't got that probe, then a tympanic thermometer is probably the best. Tympanic thermometers, are potentially a little bit erratic in this environment where the skin is very hot. But if you can get it fired at the tympanic membrane rather than the side wall of the ear canal, hopefully you'll get a more sensible reading. So you want to differentiate your patient as quickly as possible, and once you've identified the cause, you want to treat aggressively. Clearly, if they're in cardiac arrest, then that's down one algorithm. But let's say this is exertional heat injury. The body temperature is raised. The patient has neurological abnormality, so is confused or maybe even unconscious, and you want to instigate rapid cooling. And that rapid cooling is whatever you have available and the condition of the patient. Clearly, you need to move them out of the direct sunlight, so they will radiate heat, and so get them into the shade if possible, or get someone to hold a tarp over the top of them. Strip them off. So if they are on a loaded march, get the rucksack off them, get their clothing off them down to their underwear, maintaining dignity, obviously. And the old adage of strip, spray, fan does work. So strip them off, maintaining dignity, spray them with cold water all over the body, and fan. And the fan isn't just a little fan as you would in the theatre to keep yourself cool. It's aggressive fanning. So big piece of cardboard or whatever you've got, and really fan the patient, just to try and get the wind that you're creating to convect away some of the heat and encourage the sweating, to get the body cool. Gold standard treatment would be ice cold water immersion therapy. Clearly, in a lot of environments that's not going to be possible, but if you are planning activity that is going to be potentially high risk, and so fast loaded marches that are test events, I'm talking about a military context now. If you're planning that sort of event, then there's no reason why you can't plan to have the ability to deliver ice cold water immersion therapy at the point of injury, because the speed of which you cool is really, really important, and mortality and morbidity are proportional to the duration of hyperthermia. So you want to get these people cool as quickly as possible, and so that happens at the point of injury as far as possible. So ice cold water immersion therapy can happen. It does happen. It does happen in the pre-hospital environment, but clearly does take a bit of planning and logistics. If you haven't got that, then water, stripping the patient off and fanning them aggressively will do the job. And you want to get their body temperature down back to that sort of safe area of 38 degrees as quickly as possible. Try not to make them hypothermic. It's unlikely unless you are ice cold water immersion therapying them. So if you're using that technique, it's really important to monitor their body temperature throughout, because the last thing you want to do is make them hypothermic and start shivering, and then they're creating more heat again. So that's the broad approach to treatment. Aggressive, get them cool as quickly as possible. And generally they do make a good recovery, even though their body temperature has been 42, 43, and they've been pretty much unconscious. If you get them cool really quickly, you can expect them to make a full recovery.
So Harvey, just shifting and slightly pivoting towards acute behavioural disturbance and how some of these patients present with severe neurological deficits so that they're extremely difficult to manage. I mean, just thinking about sort of the critical care practice in my own life, and the ABD patients, along with sort of intracardiac arrest awareness, are probably two of the most difficult cohorts of patients to manage. And so to have a heat exertional injury, which is sort of almost mimicking an ABD, is, I can imagine, is extremely difficult to manage. How would you approach such a patient, and what kind of treatment would you look to institute?
So I would say that acute behavioural disturbance is probably the most challenging condition to treat in the pre-hospital setting, and far more challenging to treat than exertional heat stroke. The pathophysiological processes, it's probably some similarities in essence with the acute behavioural disturbance. You've got the effect of the drug on the body, both physiologically and psychologically, and so you're trying to deal with both. But in terms of the physiological process, a lot of these patients are really, really hot. And if they are really, really hot, that is going to do, bad things to them, as well as all of the psychological issues as well, and the fact that they are a danger to themselves and others through the effect often of the drug. So you've got to try and treat both, and clearly you've got to gain control of the situation before you can try and cool them. But it is worth remembering, and I think we forget quite a lot of the time, that so a lot of these patients are really, really hot, and their exertion in the management of their psychological state is making their heat injury worse, and so it's even more imperative to gain control quickly, because the longer these patients are exerting themselves and fighting you and fighting everyone else, they're also doing significant damage to themselves, whether that's the kidneys, the heart, or the brain. And so I always try to factor in, that they are hot, and that gaining control is really, really important. And the quicker I can gain control, the better, because then I can address the physiological processes as well. So the pathophysiology is probably tenuous, but the end goal has to be to get control and to get these patients cool, as well as gaining control of the other elements, the airway, the breathing, etc.
So Harvey, as we're sort of starting to come into land on the conversation, could you maybe speak to your experience of the evolved sort of way that the military plans and executes selection courses to sort of prevent exertional heat illness in sort of the current climate?
Yeah, absolutely. So in the military setting, we're never going to get rid of heat injury. We exert people, we test people physically. We want people to be psychologically robust, and so they push themselves hard, and so they're putting themselves at even greater risk of heat injury. So we're never going to get rid of it, but it's really, really important that we absolutely minimize the morbidity and mortality to as low as reasonably as possible, and that comes with significant education, risk assessment, and shared responsibility. So this isn't just the responsibility of the medics. The medics really intervene when things have gone wrong, where the focus should be and is around the commanders and the responsibility that they hold to risk assess and deliver safe and effective training that tests the individuals, but in a safe environment. And so there's a whole set of policy around prevention, and where our focus is all about prevention and education. And when it comes to activity, yes, the medical plan is important, but it's really we need to intervene before that. So we need to make sure our people are well prepared, they're well hydrated, that they've not been drinking alcohol, that they're well slept, and that they haven't got any intercurrent illness. So it's making sure people are fit to undertake that activity, making sure the environment is right. The use of the wet bulb globe thermometer reading is part of daily life in the military. And that reading is important to sort of govern the activity that we should be embarking on. So we don't want to be embarking on very, very high physical stress events when the wet bulb globe thermometer reading is high. And it's probably worth just mentioning the wet bulb globe thermometer reading. It's not just a simple temperature reading. It's a reading that takes into account or has a high focus on the humidity, but it takes into account humidity, temperature, wind speed, and radiation, as in solar load. And there's a complicated algorithm that throws out a figure and that figure is an important guide to the sort of activity that you can undertake. So we as a group of commanders are guided by the wet bulb globe thermometer, and so we won't instigate activity when the wet bulb temperature reading is too high. So there's a huge amount of stuff that goes into planning activity and to try and mitigate a lot of the risks, and to try and make those risks as low as possible without taking away the requirement to test individuals. So that's where our focus is. That's where our focus has been in the last 5 years. Every soldier, sailor, and aviator has to do, heat injury awareness training, and that's really important. It's really important that the end user understands, but probably it's even more important that the commanders and the leaders do this training as well, so that they understand, the importance of it. Because once it gets to the medical element, it means that something's gone wrong, and you're not going to get rid of it. But hopefully, the medics are going to be dealing with the minor stuff rather than the significant stuff that gets the unwanted headlines and causes significant distress to lots of people.
So Harvey, as we do come into land on the conversation, could you maybe speak to a seminal case you've been involved with? I think, from my own practice, nothing sort of speaks as loud as experience and then reflection on that experience, because, all the information, anecdotal or empirical, comes to life around you when you have to navigate some really tricky and challenging cases. Could you maybe speak to a seminal case and what you've learned about sort of the nature of heat injury in practice?
So I suppose my first real exposure to heat related injury was in large volumes was in Afghanistan, when we first went over to Afghanistan in 2006. And I suppose the first case I had to deal with was not a classic exertional heat injury, but was I suppose almost a classical heat injury, in that a soldier had got very, very, very hot inside an armoured vehicle, wearing lots of kit, and in the back of an armoured vehicle in temperatures of 40 plus degrees. But more importantly, our armoured vehicles had come from Germany, where we were used to having to prepare to fight in very cold environments, and so none of these armoured vehicles had air conditioning, and so the poor guys and girls in the back were just cooking. And the first case that I dealt with, and I'll never forget it, is someone who was literally had become more and more confused and eventually unconscious in the back of the tank, sat in their body armor and their kit, being transferred across Helmand province, and he'd been dragged out of the back unconscious. And I wasn't far away from the casualty, but the guys and girls in the back, his colleagues, had instigated really, really effective strip, spray and fanning, and had got all the clothing off him, got his kit off him, and cooled him to a point whereby he was able to be conveyed back to my facility, and then we evacuated him back to the field hospital. And he made a full recovery, but I was surprised at the degree of abnormality in his blood tests at the hospital. So he had raised liver enzymes, he had acute kidney injury, he had clotting abnormalities, and he had started the significant multi-organ failure that people do, even with a fairly short duration of hyperthermia. And so I suppose that brings me on to the other key point, whereby if people don't recover quickly, as in within 30 minutes of an exertional heat injury, they really do need to go to hospital, and they do need blood tests, and they do need their blood tests at 24 hours to make sure that their organs aren't failing. And I won't forget this chap ever, because it really taught me how effective rapid cooling is. And if you leave these people hot and you transfer them hot to a medical facility, all you're doing is increasing their chances of mortality. And what you really need to do is cool them and then convey them, but then keep them, even though they might be, to all intents and purposes, recovered. So that's my seminal case. Not really a classic exertional heat injury, but a young fit guy getting very, very hot and getting very cool, and getting cool very, very quickly.
Harvey, listen, thank you for your time today. I really do appreciate both your perspectives, your opinions, and what we'll do is we'll signpost in the show notes to some of the empirical literature, some of the seminal cases, or indeed literature that is available, so that people can read up on exertional heat injury. But just thank you for your time today, Harvey.
No problems at all. Thanks, Lou.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.